All right, we are starting. Welcome, everybody. This is Chuck at Healing Centers. This is a cool one today, guys. We've got Dr. Ryan Oakley, a psychiatrist in Nashville, Tennessee. Let's see. I'm going to say a few things, but I'm going to let him explain it even more because he'll do a tremendously better job than I will. But, he practices mindfulness, acceptance, and commitment-based treatment approach in his practice. And he is a student, if not expert, on psychedelic psychiatry, but I would probably caution that there are very few practicing psychedelic psychiatrists because it's not actually approved at this point. But that's what we're going to learn about today and dig deep on. So let me play this quick loop, and we'll be right back with Dr. Oakley.
As a therapist, I found it is sadly unusual to have a medical provider who is empathetic, knowledgeable, unhurried, and above all else, relentlessly devoted to getting you better. In fact, I never saw it until Dr. Michelle Cochran. Whether it's through genetic testing, an extremely thorough eval, TMS, or nasal S-ketamine, she finds a way. Being in network with most major insurance companies, and now with 3 locations across Middle Tennessee, Dr. Cochran and her team at the Neuroscience and TMS Treatment Center have only multiplied their level of care. Go to our website, healingcenters.co, to learn more or schedule an appointment today.
Welcome, Dr. Oakley. How are you, sir?
I'm doing well. Thanks for inviting me.
Oh, yeah. Thanks for coming. Okay. So, I pitched this thing as, psychedelics. Psychedelics and psychiatry, which is probably a loaded topic in terms of what it is and what it can be.
Got a lot of history.
I'm going to throw out a few buzzwords just to make it sound like I know what I'm talking about.
Sounds great.
But after that, I'm going to cue it over to you. But basically, in my general research or general knowledge, then basically psilocybin, some sort of mushrooms that sound really awesome, if you're into that. LSD, MDMA or Molly, and ketamine or esketamine. And I'm sure there's probably more to psychedelics, but I think those might be some categories that people have heard of and know about. And but I don't know, what do you think? Tell us a little bit about, maybe do a better background on you, and then give us a little background on what psychedelics is in psychiatry, if that
Sure.
if that makes sense.
Yeah, that sounds great. So background on me, like you said, I did a little bit of training in mindfulness at the Osher Center here, part of Vanderbilt, to sort of deepen that part of my practice and try to infuse that into my psychiatric practice, and also training in acceptance and commitment therapy, which is just based on just having people rediscover or discover their values and tapping into the resources to live more in accordance with that. And just it kind of actually uses a little bit of mindfulness as well, but it's a lot of patient agency driven and just trying to get people to live a better quality of life, which I think was influenced, or at least is part of what draws me towards the psychedelic conversation as well, because there's a lot of it. Mindfulness and acceptance commitment are based a lot on the patient choosing to daily do things that are healing.
Okay.
And are making active changes in their life, and that has a lot to do with active changes in their life towards healing, which is a large part of what psychedelics are and where their power is. So psychedelics.
Right.
I don't know, did I make that as clear as mud with my background?
We're here to learn. So
yeah. So with psychedelics, I became interested in psychedelics and studying psychedelics mainly from a literature review perspective. Third year of my training at Vanderbilt, to just kind of getting a little bit burnt out on conventional psychiatry, and what psychedelics. We'll go into a little bit of what psychedelics are. So like you mentioned, psilocybin is what you'd think of as magic mushrooms. MDMA is like ecstasy or Molly. LSD is conventionally known as acid. And ketamine is what was, I think, usually, it's a dissociative anesthetic in medical places, but has some street value as well. And then S-ketamine is just a special formulated version of ketamine that's easier to administer and also important to know that those street versions of these are not the same thing as what's used in what we're going to talk about.
Oh, is that right?
Yeah. So,
well, I know esketamine is specifically different than ketamine, but how are the others different? How is LSD different in a clinical trial versus what they would buy on the street, I guess, you know?
It's mainly control, right? So in a clinical trial, you are working with a chemist or a distributor that you know is being very careful about how they're creating the substance, and you know exactly the potency of what you're getting. Whereas if you buy it on the street, it's probably LSD.
Maybe.
Yeah, and it's maybe the potency, like the strength.
Maybe a little nutmeg sprinkled on it. You never know.
Yeah, or something more nefarious. And I think that's a lot of with MDMA and ecstasy. MDMA versus ecstasy and Molly on the street, that's a real big risk, because a lot of the times it'll be cut with amphetamines or stimulants like meth and other kind of stimulants on the street or other things.
Sidebar: why do they do that? Do they make more money that way, or is it a bigger high? What is going on with that?
You can probably get away with a little bit less of the active component of MDMA, which is a little bit harder to come by, and just mix it with something that's readily available.
Yeah,
a little bit more readily available, like stimulants.
All right.
So on the street, you don't necessarily know what you're getting. Whereas in a clinical trial, you're working with a chemist who is telling you this is what this is, and this is the strength of it.
Okay.
And the same with mushrooms too. Like if you get mushrooms on from somebody you don't trust, you don't even know if it's the right kind of mushroom or what the strength is. So
let me don't let me take you from where you don't want to go conversationally, but
no, this is good.
What happened? You know, anything I read that 60s.
Mm-hmm.
I grew up in a sort of fairly conservative household. And, the whole don't say, just say no, was kind of pounded in my brain and things like that. And, it wasn't until I was an adult, older adult, that I realized, wait a second, the hippies might have been onto something. And maybe they weren't hippies. Maybe they were actually pretty clever in where they're going. So I guess what happened with the history of psychedelic research versus, party drug, because there was some genuine research that was done legitimately and done very well and showed some promise early on, right?
Yeah, yeah.
So what happened with all that?
So it goes back way, way, way. So the plant-based ones like psilocybin or the mushrooms, those go back 7,000 years. So those are used in like really, really ancient traditions, usually in like spiritual rituals and those kinds of things. It came to modern attention and clinical attention in the 60s and 70s.
Okay.
Where they studied LSD, mescaline, and psilocybin in trials, and we're having some pretty promising results. They weren't as well designed as some of the trials are these days, but the results they were getting were pretty profound.
So they had clinical trials. They were moving forward with them, a little bit rough around the edges, but definitely showing some promise.
Yes. And then some of those same folks that were running the clinical trials, the scapegoat for it all is Timothy Leary. Have you heard that name? Yeah.
So well, I know the name in the song. Right?
Yeah. Is it the Moody Blues? So he was a Berkeley trained psychologist that was then staff at Harvard for a little while, and he was did a lot of studies on this and saw their potential, and then took it maybe one step too far. To where at first they were being careful. There was controlled experiments. They were trying to use them in a safe manner, and then it became everybody needs to do LSD. Everybody needs to do psychedelics because it'll cure society or it'll help society.
So just a few steps too far.
A few steps too far.
Let's move away from treating depression to solving the world, everything, or whatever.
Right. And then when you take these out of the clinical context and you put them into wider society where everybody's using them, the setting is, it's not in like a clinical place where you feel safe and secure with a therapist and you've been prepared for the experience, you know what's going to go on. Suddenly you're doing it at Burning Man, or you're doing it in your acquaintance's basement where like somebody could barge in at any time. And are you really safe there? These are really, really powerful medicines that if you do that in sort of unsafe or insecure settings and you're not sure what's going to happen, it can be traumatic.
So how did the wheels come off on those those early clinical trials?
So it was also a little bit of bad timing. So I think it was Nixon was in the 70s. Yeah. So some of those bad experiences through widespread use, through uncontrolled use, led to like psychotic breaks. So people losing touch with reality and not coming back because of traumatic experiences or being the wrong person.
Right.
So that comes to the attention of society and also the government, and they're already kind of inching towards, for lots of political and not so great reasons, looking for a reason to criminalize substance use.
Yeah, they did not like the left hippies category, if you will.
Yeah, they didn't. There was things that they were saying that were not conducive to, or not good for their form of government.
Right.
We won't go too much into that. But that led to the creation of the Controlled Substance Act, because you're having these experiences of like negative experiences. The government used that as sort of fodder, as like ammunition to put down this Controlled Substance Act that scheduled all psychedelics as Schedule 1. And what that means is that they're both dangerous and there's no therapeutic use. There's no clinical use for them at all.
Schedule 1, that's the kiss of death in terms of pushing legitimate clinical trials or anything like that.
Yeah, the funding dried up real quick after that. It became extraordinarily hard to study these, and like you couldn't use them outside of like if you used them, you would be prosecuted.
Like no lab could even start a clinical trial because they couldn't even get any substance for any.
You could do it, but you have to jump through loads and loads of hoops in order to get something.
And so it just shut down.
It just shut down.
Okay.
For 50 years, these were basically just not even touched because
Has it been 50 years? Wow.
Yeah. It was about 50 years before like today, where it's like getting a lot more attention. In the early 2000s and like maybe late 90s, there was some reignition and sort of restarting of the fire. But it's not until the past like decade or so where it's really kind of lifted off.
Okay, so what was the turning point?
There was one gentleman in particular gets a lot of attention for this. He's the leader of MAPS. Oh man, Rick Doblin. I was trying to remember his name. But it's this organization that basically never lost hope.
Okay.
It's a multidisciplinary association.
They've been fighting the fight for 50 years.
Yeah.
And just keep going.
They just keep going, and he's the one that's actually doing a lot of the trials with MDMA. Or he and his association, the MAPS, have been doing a lot of the MDMA for PTSD trials.
Okay.
So the ecstasy for post-traumatic stress disorder. And he's just been pushing real hard to get these back in because he recognized the therapeutic potential.
Okay.
And now psilocybin is also getting a lot of attention. So that's the magic mushrooms, is getting a lot of attention for depression, for treatment-resistant depression, and just regular depression.
So what is the effect of the Schedule 1 category on these medicines now, and are they changing them?
They have not changed them yet. However, they did give them the FDA gave them a breakthrough designation. So they're still they're still Schedule 1, but by the FDA saying that they're a breakthrough treatment for these really, really hard to treat conditions, allows them to be a little bit easier to study and sort of fast tracks the whole process.
So there was a little
bit of a window,
sort of a backdoor or window or something like that. And so which ones have fast track? And I think I read a few that have. Which ones?
So MDMA and psilocybin currently.
Okay.
LSD is probably not going to get as much attention in recent days just because of the loads of baggage that it has. That's the one that everybody kind of thinks about with the 70s and the 60s and all the use. And just the way that it works. So psilocybin, the acute effects, so like the sort of psychedelic effects that it has are like 6 to 8 hours. LSD is 12 hours.
Huh.
So if you're thinking about how you're going to do this in a clinical setting, 6 hours is a little bit more manageable than a 12-hour experience. Yeah.
Interesting. And so I know you and our partner clinics will do ketamine, which is, I guess, the version of ketamine.
Yep.
And is it? Am I right that patients will be laid up for about 3 hours? And laid up, I mean, in a professional treatment setting.
So the S-ketamine is like an entrant. You do it through the nose. Basically, you just sniff it, kind of like a Flonase, but a much more powerful Flonase.
Yeah, that's a good Flonase.
Yeah, and it's usually a 2-hour experience, maybe 15 minutes on either side, just to kind of get you settled in.
Okay.
And I would say it's more of like a psychedelic-like, in that like at some point in the process it starts to have similar effects, but it's not quite like psilocybin or LSD. And also MDMA is a little bit different so ecstasy is a little bit different than psilocybin and LSD. And then S-ketamine is a little bit different than all those other ones too. So they all act a little bit differently. But so S-ketamine, 2-hour experience, you have some similar like sort of dissociative psychedelic-like experiences on that.
Okay.
What other questions do you have? I can get lost in the weeds here.
No, that's okay. No, because I'm interested. Strictly, I'm not interested because I want to do it. I'm just interested, just casually. I'm just interested. No, so you got S-ketamine, maybe a little bit about, from a layperson's perspective, what I'm thinking about are a little more high view type questions, because I just don't know. So, what are the potential, and I guess we don't know yet because it's not necessarily FDA cleared, all the way, but in terms of clinical trials, what do each of these, I guess medicines, if that's what you want to call them, or drugs or whatever, what do they seem to be doing well with treating? For example, I think I know esketamine is cleared for major depressive disorder. Is that right?
Yep.
They call it MDD.
Treatment resistant. So people that have failed multiple medications and other treatments can be approved to get esketamine.
Right. But in my reading, you got OCD, you got PTSD, and you got I hear a lot of the common ailments as potential beneficiaries of some of these.
Yeah. Some studies have shown that it's helpful. Esketamine and ketamine are helpful for PTSD. So folks that have both major depression and post-traumatic stress disorder, there's some evidence that's showing that esketamine and ketamine can be really helpful for that.
Does MDD and PTSD manifest together much?
A lot of the time. So most folks that have failed lots of treatments for their depression usually have post-traumatic stress disorder or some sort of exposure to severe trauma. So they usually do come. So especially treatment-resistant depression often comes with PTSD.
So what are they looking at with Molly or MDMA?
It is. That one has been primarily studied with PTSD.
PTSD?
So post-traumatic stress disorder.
Okay. And what about LSD?
LSD, we'll group LSD and psilocybin together. So again, LSD, not too much being done with that. In the past, LSD did everything that psilocybin did, and they used it for alcohol use disorder as well, and it had pretty decent results there.
So alcoholism?
Yeah. So there's actually with ketamine and esketamine as well, there's some, it's not approved for it, but these are also potentially, all of these, I would say esketamine and LSD and psilocybin are potentially pretty good treatments for substance use disorders, so addiction.
Substance use and addiction.
Mm-hmm. But the one that is getting the most attention these days, psilocybin or magic mushrooms, is for depression, specifically for depression.
Well, and is that because, depression, I guess it's just more widespread, if you will. Yep. And it's maybe a more fundable research, because you got a lot of potential patients in the clinical trial. Is that how that works, or does it have any influence on that?
Yeah, it's the way into reapproval, into kind of reducing the schedule, so making it a little bit more approachable so you can study it for other things. So lots of people have depression, and depression is one of the leading causes of disability. Mm-hmm. So I think in 2020 or 2021 it was responsible for $326 billion of lost income or economic insult to the U.S. economy alone. Right? Yeah, so it's a huge. And
how do they quantify that? Just in terms of lost work?
Lost work. Worst case scenarios: early death due to suicide. So lost potential there. Losing the job. Lost work is losing the job or just not being able to show up to work because you're so severely depressed. Yep. Importantly, so all these, it's important to know that these are not just medications that you just kind of take and they take all your symptoms away, right? So you don't just take it and you have this experience and then you go about and suddenly you're cured. All the with the exception of esketamine and ketamine, when we're talking about MDMA or ecstasy or psilocybin and magic mushrooms, all the clinical trials are the medicine in combination with the psychotherapy.
Right.
So beforehand, they're preparing people. They're saying hey, you're going to take something and you know what? You might lose your ego, or you may lose the separation of yourself from the rest of the world. you might relive some really, really intense things. You'll have very, very intense, potentially really scary experiences while you're on these things. So they prepare you beforehand and give you the tools you need to handle those experiences whenever they happen.
Are you aware enough to manage that?
It depends.
Yeah.
Which is why also when you're doing this, you have most of the trials will have two people in the room with you. So two people you've developed a trusting and safe relationship with, usually therapists or other clinicians or other people that have potentially been doing this underground for the past 50 years too. So they're in the room. So they teach you the skills to try to handle these really intense experiences. If you can't, they're in the room there too to kind of help you make sense and bring you back down to earth at times. So they prepare you. They're there in the room for you whenever you're under the psychedelic treatment. And especially the MDMA and even some of the psilocybin trials afterwards, when you're not on the psychedelics, they'll meet with you after you had the session to make sense of what you went through. So it can bring up a lot of really intense things, a lot of uncomfortable memories, or potentially like really like groundbreaking insights, or just really hard to describe experiences. So you meet with these same clinicians or these same like therapists or other folks that you've developed this trusting relationship with to make sense of what you went through. And that's thought to be that's what they're being studied for. And that's where I think the real power is. It's not just taking a medicine and then you're cured. It's taking the medicine, and there are some effects on the medicine there too, but taking the medicine and then also making sense of the experience and creating potentially new ways of thinking, new ways of being that are healthier for you.
With a professional therapist. They can help guide you through that. Isn't that interesting?
Yeah.
So where's weed in all this?
So not as well studied from like a psychotherapeutic standpoint. There's no large trials going on for this. There are some studies that are studying it for maybe for PTSD and other things. It's there's some forms of weed or components of weed that are used in seizure disorders, and some is being studied for anxiety and also for chronic pain.
Right.
But I would say the research or the promise is not quite as evident or is quite as obvious in the literature right now.
But that's certainly accessible.
It's very accessible.
Yeah. And so what's the word to the wise on that, in terms of in your practice when someone, maybe hitting a few Snoop Dogs from time to time, I guess it all depends on what their situation is, but what is your overall
My thought on substances in general is like, it's kind of like with alcohol and kind of like with weed, though one is more legal than the other, is what are you using it for? So if you're using it every single day to treat something, to like avoid an experience, or because you can't, like the distress is too much and you're becoming like psychologically dependent. So you need this in order to feel good and you're avoiding painful experiences because of this, that gets dangerous, I would say. Because these are also medications where you can create physical dependence. So not just are you psychologically and like you're mentally dependent on them, but your body becomes used to them too. So where you have withdrawal afterwards. And the withdrawal makes all your symptoms worse, usually. So for weed, I would say if you use it daily, and this is a thing that isn't really talked about a lot, but folks who smoke daily and we'll say daily and at fairly a good amount of hits off the pipe or the joint can have pretty bad withdrawals if they go a couple days without it.
Is that right?
Mm-hmm. So their sleep gets disrupted. They might become more depressed. They'll get more anxious. They can get nauseous. A lot of the things that lead them to think that, okay, well, now I need to smoke weed in order to become less anxious is actually they're just treating withdrawals from marijuana at that point.
Interesting.
Yeah. And that's where I think, so these psychedelics, you're doing 2 or 3 sessions separated by like 2 or 3 weeks in between. So you're not doing this every single day.
2 to 3 sessions.
Oh, so 2 to 3 medicine sessions. So 2 to 3 times where you're taking the psychedelic, having the psychedelic experience with the 2 clinicians or 2 people in the room with you. So you're not doing it every single day. You're just having 2 or 3 pretty big experiences.
And so what's the time gap between typical treatment?
I'd say usually about 2 to 3 weeks has been most of the.
So within a month and a half,
Mm-hmm.
You would have gone through, I guess, a full course.
Mm-hmm.
Is that the right way to say it?
Yeah.
Right.
The protocol is different, or the design is a little bit different.
And so, are any of these that we talked about addictive if you don't follow that structured protocol?
I would say MDMA, I'd be a little bit hesitant because there are stimulant-like properties, so things like Adderall, and it has some properties that are similar to that, to where if you did take it every single day, you could potentially have a physical dependence. LSD and psilocybin is primarily a psychological dependence. So if you're using it every single day, usually it's to escape something.
Huh. So it's not, your body isn't necessarily demanding it, but
your mind is.
Yeah. Isn't that interesting?
Yeah.
Isn't that interesting? All right. So, that's the framework of it. Thanks for sharing that. It's really interesting to me, as a public school kid who might have been exposed to some of these milder things, definitely not the bigger ones. It's interesting to see it come around to some traditional treatments and support systems and things like that. So that's exciting. Well, what is the timeline on this? If somebody's listening, like, man, this is cool. I want to give it a shot. Where does one go? It's not like you can just go to the drugstore and grab some of this stuff.
That's very true, and there's good reason for that. So MDMA, or the ecstasy for PTSD, that is undergoing one of the second confirmatory trial. So it's hopefully scheduled to be FDA approved by the end of 2023 or early 2024.
All right, so
pretty soon.
Fairly soon, all things considered. And you said that's the second clinical trial? Is that what you said?
So the drug approval process is like this large onerous beast that people have to go through. For some for good reason and some for just like, okay, dude. Yeah.
Okay.
But so they're nearing the finish line.
Okay.
For MDMA. Psilocybin's probably another 3 or 5 years down the road, I would say.
Oh, really?
Mm-hmm.
So MDMA may be the first one after S-ketamine. Is that right?
I would say so.
And people, let's see, am I correct that physicians, S-ketamine is a version of ketamine that's FDA cleared for the treatment of depression.
Yep.
But is ketamine also available in a treatment type scenario?
Yeah, there's lots of different of these clinics kind of popping up of variable quality, or how they design their treatment can be a little bit variable and maybe not always so great. So ketamine is available. It's usually cash pay because no insurance will provide it. No insurance will pay for it specifically for psychiatric reasons.
Ketamine, however,
S-ketamine is approved by most insurances if you've failed lots of other treatments. You usually have to fail like at least 2 different medications for depression.
But I've even seen that with our partners is they, they'll go through the prior authorization process and they'll find out for you.
Yeah.
If insurance is going to pay or not.
Right.
And so no harm, no foul. If you're interested and want to check it out, that's certainly a FDA cleared, appropriate. Where would one, if they're looking through their Rolodex for you young people, that's like pieces of paper with addresses on them that you can find people.
Thank you. Yeah, that's helpful for me.
Thank you. And but where does one look to, what resources does one go to find it? Obviously you will put your contact information in there, but
so that's one of the things we do at our practice. And so the VA does it currently. So if you're a veteran, the VA has programs at most of the larger treatment centers around the nation. You'd have to look around. I know if you look up for S-ketamine providers, you'll probably find several different treatment centers. So it has to be done should be done in a treatment center.
Yep. So is it safe to say to use board certified type psychiatrist, if you will, reputable clinic, S-ketamine, which is FDA cleared and hopefully covered by your insurance if this is something you're interested in, as opposed to a pop-up ketamine shop, which may or may not be.
Yeah, some of them are run by anesthesiologists or emergency physicians who don't really have a lot actually I would say emergency physicians probably have a little bit of experience with psychiatry, but that's mainly just where we're at with psychiatry treatment. So a lot of them aren't run by psychiatrists. So you want to look for one that probably or definitely want to look for one that has a psychiatrist on staff that's actively involved in the treatment process and the design.
Not somebody that comes by with a clipboard once a month to check off on charts. Somebody that actually looks at stuff and talks to people. And things like that.
And I'd be very, very wary. There's a lot of things done now where people will get ketamine delivered to their home and they'll do a telehealth session or something. So
you're self-administering this stuff.
You're self-administering this stuff, and some of them will ask you like, hey, make sure you bring a friend with you so that if you have a bad experience, they'll be there for you. I wouldn't test it.
There's got to be some liability in there somewhere.
I'm sure there's lots of things you sign.
My goodness.
But I mean, people are really suffering, and they want to find some sort of solace and some sort of improvement in what they're going through.
That's fair.
Yeah,
that's fair. But if it's FDA cleared and insurance covers it, then it seems like that might be
it's usually
the better direction.
Yeah.
To go in.
You want to do it in a place that has an organized and a secure and sort of like a well-designed process.
So what is, and again, don't let me take you where you don't want to go, but
I need to be directed, Chuck. You probably noticed that I will wander.
What is the psychiatric office or a therapist office look like in 10 years from now? I've been joking. It's, you're coming with beads, man. What do you want? MDMA, got an LSD in the back. Oh, it's ketamine. That's on the right,
Yeah.
Take your choice, man. It's all good. Pink Floyd, Jefferson Starship. It's cool. What do you want to listen to?
We'll say that music is actually a pretty important part of the psychedelics.
Oh, listen, I've already got my list of albums that I want to play. I'm a little more old school than you, but Pink Floyd would probably be up on the top.
Yeah, that sounds great. So I would say it probably won't be so free floating. Again, we don't want to get caught in the trap in what happened in the 70s.
Because that kind of is what happened, wasn't it? I mean, they just started to drink the Kool-Aid, so to speak.
Yeah.
And kind of overprofess what it could really do, and just take it for everything. Yeah. Is that what's going on?
Yeah. It's a snake oil thing. So and it could be helpful for all these things. We don't know that, and they're really, really powerful and could potentially be really traumatic. So it's got to be done safe.
So they just got ahead of the curve on that one. So this time around, be a little bit more slow, a little more methodical, more thoughtful.
Chuck, I hope so. But they just these guys, some of the ones that are actively involved in the research right now, just wrote a paper and said, like, we're seeing a little bit of the similar things happening this day and age too.
Well, isn't that interesting? Is it because I don't know, just they're too passionate, or
the clinicians themselves? So the ones that wrote the paper, they're doing things very methodical, and so most of the ones that are involved in the studies are trying not to get too ahead of themselves. But when you start publishing these things in the newspaper, and you say like miracle cure, or like, oh, this is a breakthrough treatment, it's hard not to get excited about that, right? But then people start getting ahead of the curve. It's like, oh, well, let's decriminalize. Let's decriminalization. I have varied views on it. Let's decriminalize it. Let's start doing it. Let's start using it in widespread audiences and just see what happens, because this will be really helpful. It's like, no, that's not how these are working.
Too much too fast.
Yeah, too much too fast. And like, it's secure for everything, and like, just do this and everything will be better, and just not putting it in the proper context.
Huh.
Yeah. And the fear is that with that hype, you start having really bad experiences again. Those get mainstream publicity again, and then the government cracks down again, and then it shuts down for another 50 years.
So we need to keep some controls on it.
Need to keep some controls on it.
And any reading I've done really professes exactly what you just said, that it's definitely not the medicines by itself. It's only in conjunction with, professional therapy.
Yes.
Right. Mm-hmm. And I'm sure that's even the case with TMS, that transcranial magnetic stimulation, or other I guess non-traditional. Is that the way? It's non-traditional treatment options. Is that a fair way to categorize?
So I would say interventional.
Interventional.
Yeah, it's kind of that where you're doing something pretty. I don't know. Like most of what we do in psychiatry is a little bit interventional. Even when you're taking a common antidepressant, you're changing the brain chemistry a little bit.
Okay.
But when you're using TMS and putting a magnetic coil on the brain, or when you're doing ECT and just like kind of resetting the circuits a little bit, those kind of dip into the category of interventional.
Okay.
And S-ketamine's there too.
So how did you get interested in this topic? You worked at the VA, is that right?
I did, yeah. So in my training, I worked at the VA.
Is that where you got interested in this topic?
I was actually interested in this about third year of my training, just being a little bit kind of, I think I'd hinted at, like a little bit burnt out on conventional psychiatry. It's just knowing that like the treatments that we have so far, some of them can be really helpful, but when you have, like we were talking about, like depression with like pretty severe trauma or PTSD, and you have so many of these complex cases where just the medicine isn't gonna help. Things like psychedelics used in the proper context have just shown really, really amazing results. So the MDMA for PTSD, they're trying this with patients that have been like resistant, like treatment resistant PTSD. So they have like trauma, not only from just like one really traumatic incident that caused like some of the classic PTSD symptoms, but folks that had severe childhood trauma, things that have been through over and over really, really terrible experiences that have been extremely hard to treat. MDMA has been able to treat that.
Interesting.
So there's just such really amazing potential to treat populations and folks that have been suffering from really, really severe conditions where nothing else has worked.
And when it's less severe, is it treatable without these type medicines, or has it been?
Yeah. So I think like the conventional antidepressants and other medications like that can be very helpful, at least to give you like a response to decrease the symptoms,
right,
and help you get back to your life. But even those, it's like 50% will respond, 30% will go into complete remission. So like have no symptoms and have no dysfunction.
So do you ever see any of these being first line tries, for the doctor? I've got a little depression. Let's try some LSD. Call me tomorrow. See how you feel. Is that it?
That's what's interesting. So MDMA was primarily for treatment-resistant PTSD. S-ketamine is for treatment-resistant major depression. Some of the psilocybin trials are being used for just depression. So that was an interesting.
Interesting. So that's the one that might be more first line than the others.
Yeah,
maybe.
I would be curious to see what the FDA, so the people that the organization that approves drugs and all those things, if they'll be cool with that. If he's saying like, yeah, try it first line, no problem.
Yeah. Do you worry that people, as this starts to become more to the forefront, do people sort of invent symptoms? I think I do. I think I have PTSD. I do. I think, or no. Treatment resistant depression. I definitely have that. Yes, definitely.
That's where having a clinician and then getting collateral. So
who can wade through that,
wade through symptoms, and not just the report, but what are you seeing in the office, and then it would make sense to talk to family and to talk to like friends and stuff to get some information too, just to make sure it's not just being abused. Yeah,
because that's a risk, right? Yep. That's a risk. And so what does your practice look like? I mean, obviously this is an interest of yours, but, I'm sure you don't have an MDMA practice right now, if you will. What does your practice look like, and what do you like to help and see? And do.
So I'm I guess a generalist is what would be the best thing. So depression, anxiety, PTSD, trauma. I try to take a trauma-informed approach with folks with OCD and bipolar, and then some addiction. So I try to see a little bit of everything, and I try to as much as is safer as like clinically indicated to sort of give information, guide, and then see what's going to be most useful for the patient. So I'm generally not a very directive person where I say like, okay, you have this, you're going to take this, and then you're going to get better. And if this doesn't work, then it's on you.
Right.
I want to, my practice is usually, so if we're using medications, we're using it to treat debilitating. So symptoms that are just throwing you out of life, you're off track. We're going to try to reduce those symptoms, but not just to reduce those symptoms. We're going to reduce those symptoms so you start doing things that you enjoy. So you start doing things that are valuable to you. So you get back into the life that you want to live. Mm-hmm. So always with a goal in mind, and not focusing on the medicines as the only treatment, but the actual living of your life is going to be part of that treatment too.
Good.
So living a valuable life.
Okay.
Mm-hmm.
And then when appropriate, you would recommend one of the approved interventional type treatments?
Yes. So if the medicines aren't working, then we'd kind of take a scaled approach. So we go to the next thing in line. So is it S-ketamine? Is it TMS? Do we need to refer out for ECT? We go to the next line of intervention.
Okay. All right. So this is awesome. I appreciate you coming here and talking about this. But, if someone has a loved one, that hasn't had any successful treatments of PTSD, is really interested in this, I'm just throwing that as an example. How does one tap into a clinical trial or, at least make a call to see if they might be appropriate or a fit or something like that, in an appropriate clinical trial?
So if you'd have to look for some of the major medical centers that are doing them. So Johns Hopkins has a bunch of depression. If you go on Johns Hopkins in the Center for Psychedelic Studies, I think is what it's called, they have links to all of their clinical trials. And they ask questions like, are you interested in enrolling for this? So you can enroll through there. They'll go through screening questionnaires. They'll make sure that you're to see if you could benefit and to see if it would be safe for you. For the MAPS trials, I think they finished enrollment, so they finally got enough people for their most recent confirmatory trial. But even then, it's probably not a bad idea to call and to see if there's still some other studies going on. So you look up for the Multidisciplinary Association of Psychedelic Studies, so that's MAPS. They're doing a lot of different clinical trials for MDMA and other psychedelic substances. So you could look on there and see if what you got is what they're treating, and try to sign up there. We're looking at some of the larger academic medical centers like Johns Hopkins or NYU, and there's and UC University of California in San Francisco and San Diego have some big trials going on.
Okay.
So they're not, unfortunately, these things aren't all over the place yet.
Yeah.
You have to go to a pretty big
center.
That's all right.
Well, and you could also just see someone like you.
Yeah.
And get started there, right?
So there is potential with S-ketamine, and it's something that I'm kind of dreaming up right now and trying to write up. It's nothing put in place yet, but there is potential for S-ketamine to have similar effects to psychedelics, and can be capitalized or can be used to augment psychotherapy. So you can use S-ketamine in combination with therapy to get, theoretically similar results. Maybe not as profound because I think they act a little bit differently, S-ketamine and psilocybin, or MDMA. But I think there's pretty rich potential to potentially get some improvement that way too.
Well, that's also in practice now, right?
Mm-hmm. Yeah. So people are doing S-ketamine and then IV ketamine. There's some places that do ketamine assisted therapy.
Okay.
But it's less well studied.
Fair enough. Well, I appreciate you coming on and educating me, and hopefully anybody else listening. And I feel completely validated in my high school experiences. No, I'm just kidding. Maybe a little bit kidding, maybe not. But anyway.
Yeah. I was gonna leave with an analogy, if that's okay.
Yeah, let me.
So psychedelic substances, it's kind of thinking of trying to put them in context of what their power is. It's like a nuclear reaction. I've been thinking about this one, Chuck. I've been thinking about what's a good way to think about these. They're like nuclear reactions. So if you have a nuclear reaction within like a power plant with trained personnel in a secure, safe, well-controlled environment, you have the potential to create energy for lots of things, like really, really immense potential to help people provide the energy for all the things they want to do in life,
right.
to potentially help live a life better worth living for them. If you have a nuclear reaction outside of a controlled setting, widespread destruction, complete like trauma, and potentially setting things really off course. So very, very powerful medicines. You want to do them in the proper context with the properly trained personnel. The other thing is that nuclear reaction that's happening inside that power plant, it's got to be fueling something. So it's not just taking it and then, suddenly everything's better, and then I'll just go back to doing the same things that I'm doing, or I'm not going to make use of that energy.
Okay.
To make a change or to start living the way that I want to live. I think of it as like using that nuclear energy to power 50,000 lights in a stadium with no, like a sports stadium with nothing going on. You're just wasting a lot.
It's just energy for the sake of energy.
It's energy for the sake of energy. Mm-hmm. But if you take that same energy and you put it into maybe getting back out and walking, maybe getting back to gardening, maybe getting back out and being social and hanging out with people that you find valuable in your life, it has the potential to power you to do those things in really profound ways.
I think it's a great analogy.
Yeah,
I think it's very informative, very supportive, very hopeful, and also a little bit freaked out if you're not doing it right, which is probably the intent, right?
That's my main concern, is that it just being widely used and it causing like devastation in people's lives as opposed to healing.
Which is why we're here. Mm-hmm. I'm going to stop there. That was great. The only thing I wish now is that I could play Jefferson Starship instead of our little outro. I feel like that's a better name for it. But thank you for coming. I'm going to sign off and play our outro.
Sounds great.
Thanks.
From our studios in Nashville, Tennessee, this is Healing Centers, a podcast where we talk to experts and leaders in wellness, mental health, physiology, fitness, nutrition, and any other topic that helps us get through the day with purpose and through our life with long-term success and health. Follow us on Facebook and Instagram, and please give us 5 stars wherever you listen to your podcasts. Visit our website at www.healingcenters.co to share feedback, suggest future episode topics, and find out more about the people on our podcast.